presentation is sponsored by the Bristol Myers Squibb Foundation, the Maine Cancer Foundation, the Maine Economic Improvement Fund, which together helps fund the Maine Lung Cancer Coalition. So for today, the webinar is called Integrating Tobacco Treatment Along the Continuum of Lung Cancer Screening. And we're really looking at this from the primary care office to the lung cancer screening site. Again, I'm happy to have Ed Parker here from the Centers of Tobacco Independence, and today, as you all know, is February 27th, so we're happy that you're here. So I'm just going to go over a few housekeeping slides with everyone right now, and if you've been on our webinars in the past, this will be familiar to you. So in other words, for logistics for Zoom, audio lines or for non-presenters are currently muted, so everyone is muted at this time. Please use the chat box for any questions or comments you have throughout the presentation. If you're requesting CME for this webinar and you did not sign into Zoom through a direct link, or you're watching as part of a group, please email us at mlcc.mainqualitycounts.org. You can either do it right during the presentation, right now as you're getting set up, or immediately after the webinar so we can track your participation. Just a quick overview of the agenda today. Obviously, I'm doing the welcome and introductions, and then we're going to be able to dive into our webinar, again, Integrating Tobacco Treatment on the Continuum of Lung Cancer Screening, the PCP Office to Lung Cancer Screening site with Ed Perka. We're going to try to wrap up everything around 12:45, so we have some time to have some questions and answers, which I think is always great with this work, and then we'll wrap up at 1 o'clock. This is just to let you know that Maine Quality Count staff is working to improve the health of everyone in Maine. You can connect with us. This is our email, mainqualitycounts.org. For today, speaker disclosure and CME certificates. For the CME disclosure, the speaker today does not have any relevant financial relationships with manufacturers of any commercial products and or provider of commercial services discussed in the CME activity. A CME evaluation survey will be sent after the learning session to all of you via email. Again, which is why it's so important if you're with a group, please send us those individual emails. Please complete the survey via SurveyMonkey and return that to us in 1 week. And the slide deck and everything will be continued onto shortly after the presentation. So today I'd like to present Ed Perka, sitting here next to me. He is a New York State credentialed alcoholism and substance abuse counselor with over 20 years experience in the field of addictions. Edward has worked in a variety of settings, including inpatient treatment, intensive outpatient treatment, and long-term residential treatment. Prior to coming to CTI, Edward worked for the Research Foundation for the State University of New York, where he managed a multifaceted project to design, develop, and deliver training and provide technical assistance regarding New York State tobacco policies, regulations, and clinical program interventions in the treatment of tobacco dependence to New York State addiction service providers. So we are greatly pleased to have him with us, and especially with this wealth of experience. And at this point, I'm going to turn the presentation over to Ed.
All right. Well, hello, everyone. Welcome to today's webinar on integrating tobacco treatment along the continuum of lung cancer screening. Viewing the LDCT screening process as a continuum gives us an opportunity to intervene at several points along that continuum. And that reinforces the fact that repeated tobacco treatment interventions are more effective than one-and-done events. A patient will be more likely to accept a referral for treatment or to attempt to quit if his or her tobacco use is discussed at every point along every point of contact along that continuum. So current requirements for CMS reimbursement include tobacco treatment counseling at the shared decision-making visit and at the actual LDCT screening visit. However, there are opportunities for additional interventions at the identification or recruitment stage, for example, and at any post-LDCT PCP visit. So repetition is a key concept in tobacco treatment interventions. Our goal is to engage the patient in a conversation about smoking at every encounter. This helps the patient to process the risks of continued smoking versus the benefits of achieving tobacco abstinence. So the goals of today's presentation are to discuss the evidence for providing tobacco treatment for smokers during the LDCT lung cancer screening, and to provide recommendations on the integration of tobacco treatment into the LDCT lung cancer screening process. And here are the objectives for the webinar. We want to describe opportunities for providing tobacco treatment along the continuum of screening from the primary care office right up to the screening site. You'll also be able to describe workflow processes to support the integration of tobacco treatment into the screening process. We are going to talk about referrals to the Maine Tobacco Helpline, connecting patients with evidence-based treatment, counseling, and medication for those eligible patients. And we'll also be able to implement some evidence-based brief interventions, counseling and medication for tobacco treatment right in the context of the work sites. So some people are surprised that the overall smoking prevalence in Maine is approximately 19%. The usual perception is that it's much higher. But remember that this is an overall state figure. The percentage varies from county to county. The lighter colors on the map have a lower percentage, the darker a higher percentage. So you can see that in Somerset County, for example, it's in the higher range, while Cumberland County is in the lower range. There's factors like age and gender and education and income that all affect the smoking rate. People with lower levels of education and lower incomes tend to smoke more than those that don't fall into those categories. Now, these maps show the relationship between cancer deaths and smoking in Maine. These maps are the courtesy of our colleagues at Maine Medical Center for Outcomes Research and Evaluation, Dr. Kathleen Fairfield and also Adam Black. So among approximately 785,000 adults aged 35 plus in the Maine hospital service areas, or HSAs as we call them, 4,635 died of lung cancer between 2010 and 2014. Lung cancer mortality rates, age and sex adjusted, varied markedly by hospital service area. For example, ranging from 61.3 to 165.7 deaths per 100,000 person years. So basically, there are regional differences in lung cancer mortality and the relationship between lung cancer mortality, smoking, education, and poverty. So this analysis examines small area geographic variation in and association between all of these factors at the HSA level, focusing on identifying predictors of lung cancer mortality. For example, low education was defined as not having completed high school, and poverty as household income less than $15,000 annually. So strong correlations were observed between regional prevalence of smoking, poverty, low education, and lung cancer mortality. And services aimed at lung cancer prevention, such as tobacco treatment, may not be available in the areas at highest risk. There were marked differences between the 32 Maine HSAs in range of smoking. For example, 12.8% all the way up to 28.6%. Low education, 4.7 to 17%, and poverty, 4.4% to 21.1%. So the conclusion here is that there is substantial small area geographic variation in lung cancer mortality, smoking, and socio-demographic characteristics, which are all strongly correlated with one another. Efforts to improve prevention and screening for lung cancer should include targeting these high-risk areas with innovative engagement strategies that address these social determinants of health. So let's be clear about what we're dealing with. So tobacco use disorder is a substance use disorder, just like any other substance use disorder. Now here's an example of terms that are used interchangeably: substance use disorder and addiction, and a couple of definitions that describe the condition. So both of these are good definitions of a substance use disorder / addiction. So viewing tobacco use disorder as a chronic medical illness that requires treatment helps us to empathize more with our patients and to understand what they're dealing with. It's not just a simple matter of tobacco cessation. Treatment is a process that requires multiple interventions over time. The biopsychosocial model is used to describe the disease of tobacco addiction and all other addictions for that matter. So the biological domain pertains to the physical aspects of the disease. For example, 40 to 60% of addictive disorders have genetic components predisposing individuals for the disease. Drugs and alcohol affect the brain in specific ways. We characterize addiction as a primary chronic disease of brain reward, motivation, memory, and the related circuitry. The psychological domain describes the feelings and emotions an individual is dealing with. So frequently the use of substances is a coping mechanism to deal with feelings such as guilt, shame, and anger. Co-occurring mental health disorders can exacerbate addictive disorders and vice versa. The social domain pertains to the environment. So an individual's family situation, employment, peer group, and support system, or lack of a support system, all have an impact on the course of an addictive disorder. The biopsychosocial model is a holistic view of addiction. In order to have a successful treatment outcome, all of the domains need to be addressed in a treatment plan. So as we've mentioned, a key element in tobacco treatment interventions is repetition. So delivering a caring and compassionate message about the availability of effective tobacco treatment at every patient encounter increases the chances of a patient deciding to quit and also enhances the overall quit success. So this simple continuum highlights several of those opportunities. Discussing a patient's smoking status should occur not only at the shared decision-making visit, but also at other points along the continuum, including the identification phase and also at the screening visit itself, the LDCT screening visit. The same intervention should also be done at any other post-screening visit. The fact of the matter is that most smokers want to quit, but most are just not ready to quit. There's a big difference. The main reason that patients say they are not ready to quit is that they don't know how to quit. So having regular non-judgmental conversations with patients in which you discuss the fact that you can help them when they're ready enhances a patient's confidence and makes it more likely they'll accept your offer of treatment at one of your interventions. Now, you never know when that point will come, hence the need for repetition. Also, most patients expect you to ask and actually want you to ask about their smoking. So don't worry that repetition will damage your relationship with the patient. Patients report greater satisfaction with providers who ask about health-related behaviors, including tobacco use. So let's look at the continuum. So one of the first things you can do is to equip your office waiting rooms and exam rooms with tobacco-related self-help materials. Now, the Voices of Nicotine Recovery.com is an online nicotine anonymous 12-step self-help group. Participants can actually attend real-time Niconon meetings and have access to a variety of resources that can support them in their quit. The main prevention store has lots of goodies you can order, such as rat cards, pamphlets, and flyers that the patients can just pick up and take with them. So these are examples of what you can get, and they can be ordered free of charge. So stock up. And the Quit link has a helpline self-referral form. It's good for those patients who don't want to be referred by your office or want to do it on their own time. And right on that screenshot, you can see the link for Get Support. That's the main tobacco helpline, and they can self-refer. And for those who like to do things on their mobile devices, these links provide online tools to help smokers quit. By the way, the Text to Quit is a new addition to the main tobacco helpline program that helps participants connect and interact with their web coach, learn how to use medications correctly, manage urges, avoid relapse, all from their mobile phones. And this is all in addition to the telephone counseling and tobacco treatment medications they receive through the helpline. More on the helpline is going to come up shortly. So in the national U.S. National Lung Cancer Screening Trial, 87% of patients reported an interest in quitting. Again, maybe not a readiness to quit, but an interest in quitting. So the evidence suggests that, by and large, this population is motivated to quit smoking. So the LDCT screening process is an ideal opportunity to provide tobacco treatment interventions, not just once, but at several points, as we've discussed. The more interventions that are offered, the more motivated the patient is likely to become. So look at this, 108 lung cancer patients, 71% were very interested in quitting the next month. And of those, 74% were willing to attend a treatment group right in the clinic. So ideal time. So the Centers for Medicare and Medicaid Services, or CMS, has set out criteria for reimbursement for those who qualify for the screening and meet the eligibility criteria. CMS has determined that the evidence is sufficient to add a counseling and shared decision-making component to the LDCT lung cancer screening visit. This is an additional preventive service benefit under the Medicare program. One element in that shared decision-making visit is to provide tobacco counseling. So we see our criteria for screening, okay, 55 to 77, no symptoms of lung cancer, a tobacco smoking history of at least 30 pack years. We're going to talk a little bit more about that. And a current smoker or one who has quit within the last 15 years. So they further stipulate it has to be furnished by a physician or qualified non-physician practitioner, which would be a PA or an NP or a clinical nurse specialist, and is appropriately documented in the beneficiary's medical records. So the initial screening visit must include counseling on the importance of maintaining cigarette smoking abstinence if a former smoker, the importance of tobacco treatment if the person is a current smoker, and, if appropriate, furnishing of information about tobacco treatment interventions. And the visit to the radiology imaging facility must also include a tobacco counseling component and make available tobacco treatment interventions for current smokers. So this is required for subsequent LDCT screening visits as well, since the screening is recommended as an annual diagnostic tool. So the problem with these tobacco counseling requirements as set forth by CMS is that it leaves a lot of room for interpretation. Different organizations such as the American Cancer Society, the American Association of Thoracic Surgery, and the American Lung Association have come out with slightly different guidelines about who should be screened. But for reimbursement through the Centers for Medicare and Medicaid Services, there are specific criteria that have to be met. So to be eligible for CMS reimbursed LDCT screening, a patient must have a tobacco smoking history of at least 30 pack years. So as we can see by the worksheet, the number of years smoked multiplied by the average number of packs smoked per day equals pack years. So 1 pack per day for 30 years would equal 30 pack years, or 2 packs per day for 15 years. What if someone smoked 1.5 packs per day? Well, they'd have to have at least 20 years of smoking history to equal 30 pack years. And what about half a pack a day? Well, they'd have to have at least 60 years of smoking history to equal 30 pack years. So figuring pack years can get a little tricky if a patient has had periods of abstinence for smoking in their history, but overall it's acceptable to rely on the patient's reported history in the calculation of pack years. And there's a neat little link, www.smokingpackyears.com. There's a tool on there that you can use to actually calculate pack years. And I went on there and tried it. It's pretty neat. Check that out. Indeed, some of these descriptors on the slide may be true of older smokers, but despite the assumed too late to quit mentality, older smokers are receptive to tobacco treatment interventions and are capable of quitting in high proportions. So there's always hope for older adult smokers, and it's never too late to quit. Stopping smoking even in later years can significantly reduce mortality, including those who have already been diagnosed with a smoking-related disease. Tobacco abstinence can reduce the risk of lung cancer by approximately 50% with 10 years of abstinence. So tobacco abstinence provides immediate and long-lasting benefits at any age, and primary care providers and screening site clinicians have a golden opportunity to engage with patients and deliver brief interventions. So let's talk a little bit about the shared decision-making visit. So Treating Tobacco Use and Dependence 2008 update, a public health service-sponsored clinical practice guideline, contains strategies and recommendations designed to assist clinicians, tobacco dependence treatment specialists, healthcare administrators, and insurers in delivering and supporting effective treatments for tobacco use and dependence. Now, just a note here, since the introduction of the DSM-5, the Diagnostic and Statistical Manual, instead of the term tobacco dependence, we now use the term tobacco use disorder. So you're going to hear those two used interchangeably. So the recommendations were made as a result of a systematic review and meta-analysis by a panel of experts. The overarching goal of these recommendations is that clinicians strongly recommend the use of effective tobacco dependence counseling and medication treatments to their patients who use tobacco, and that health systems and insurers and other key stakeholders assist clinicians in making such treatment available. So this slide depicts the two major components of evidence-based treatment according to the public health guideline, which is the combination of counseling and medication. So first, we're going to discuss the counseling piece of evidence-based treatment for tobacco dependence. So the first component of evidence-based tobacco treatment is practical counseling. So practical counseling is made up of elements like helping patients recognize high-risk situations, helping them develop coping skills, and providing basic information about tobacco dependence and tobacco treatment. And then the second component of evidence-based tobacco treatment counseling is what we call inter-treatment support. So inter-treatment support includes things like encouraging the patient in the quit attempt, communicating caring and concern, encouraging the patient to talk about the quitting process. And what it really means, it's basically a non-judgmental approach and empathetic support in the context of tobacco treatment. So think about when a patient walks into your practice, and is it safe for them to talk about tobacco treatment? Are they going to be judged? Are they going to be scolded? Are they going to be shamed and blamed? That's not inter-treatment support. That's the opposite. So having a welcoming, non-judgmental, compassionate environment is what we want to do with our patients so that they're confident and they feel comfortable talking about their tobacco use. So this model is called the 5 A's. It's evidence-based: ask, advise, assess, assist, and arrange. So these strategies are designed to be brief, and they take 3 to 10 minutes to complete. They are the core elements of a tobacco intervention, but they don't have to be applied like this in a rigid manner. These elements can be delivered by different clinicians at various points during the visit. Like, for example, a medical assistant may ask about tobacco use status, and then maybe a prescriber, for example, a physician, may deliver personal advice to quit and assist with medications. Also, the steps don't need to be sequential. For example, some clinicians may want to assess the patient's readiness to quit before advising them to quit. And these are the bare bones of the shared decision-making visit. So we want to document tobacco use history. We want to provide advice about the risk and importance of quitting. Now, this is actually the tobacco piece of the shared decision-making visit. Obviously, with the screening process and the risks and benefits of that, you discussed that also, but this is the tobacco part. Offer treatment resources. So that could be medications and counseling right on site, or that might be referral to the main tobacco helpline. And then it's important to plan the follow-up. How are we going to follow up with that patient with respect to that tobacco intervention? It might be a phone call, it might be a text message, it might be setting up another appointment for them to see them. So just a little bit about engagement. So patients respond better to empathic conversations than to confrontational ones. So it's more effective to empower patients than trying to persuade them. We call it person-centered care, and that's a way of thinking and doing things that sees people using healthcare services as equal partners in planning and developing and monitoring care to make sure it meets their needs. So this means putting patients at the center of decisions and seeing them as experts, working alongside professionals to get to the best outcome. So person-centered care is not just about giving people whatever they want or providing information. It's about considering their desires and their values and their family situations and their social circumstances and their lifestyles. It's seeing the person as an individual and working together to develop appropriate solutions. So we ask and then we advise. So in a strong but compassionate and caring manner, advise the patient to stop using tobacco. Now, for those who are never smokers or former smokers, the provider will congratulate them and counsel them on the importance of remaining abstinent. Don't use judgmental or shaming statements. Patients respond best to advice if you're able to personalize their advice to their unique situation. So here's a personalized statement. One of the best things you can do to reduce your risk of lung cancer and to improve your health is to quit smoking. And make it compassionate. I understand it can be hard to quit, but I'm concerned, worried for your health. I can help if you are ready to try. So just knowing that the provider is there when they're ready can be powerful. So advise the patient at every encounter that you see them. The more a patient hears the advice, the more likely it is that they'll move in the direction of becoming tobacco-free. So by assessing, we're trying to determine how ready a patient is to quit. So many patients are motivated to quit or want to quit, but that doesn't mean they're necessarily ready to quit. So by assessing readiness, we can figure out what to do next. Now, a great way to assess readiness is using a scaling question, like on a scale of 1 to 10, with 1 being very low and 10 being very high, how ready are you to quit? And then if somebody says, for example, 6, then the provider can say, what needs to happen for that to become a 7? And that's the wheels turning with the patient's mind, and that starts that planning process. So not every patient is going to be open to receiving information or to talk about making a quit attempt. However, for those patients who seem willing, assisting him or her in making a quit attempt by offering medication and counseling or referring to the main tobacco helpline is the next step in the process. So some clinical settings will prescribe tobacco treatment medications, either nicotine replacement therapy or non-nicotine medications like Zyban and Chantix, and also counseling to help the patient quit. And you can see on our slide, practical counseling is things like setting a quit date, how to deal with cravings to cope with stress, high-risk situation routines, have handouts and information available for them, and always offer them encouragement and support. And just very quickly on a quit date, if someone says they're ready to quit, and one of the most important things you can do is you can set a quit date with them. And the quit date should be somewhere between 2 and 3 weeks out. And what this does is it takes a hypothetical and it changes it into a reality. So that patient has that, they really have that set in stone now. That's when I want to quit. If somebody says, I want to set a quit date, but I want to set it 6 months from now, then they're really not ready at that point to make any kind of serious quit attempt. So best practice, arrange for follow-up. For the patient who is willing to make a quit attempt, arrange for follow-up contacts to check in with the patient and see how they're doing with their quit attempt, and also to offer them encouragement and support. And usually that's a day or two after their quit date. So if they set up their quit date, and that comes, a day or two goes by, that's when follow-up can really be important. It's a very important step in the 5 A's, and yet it's often overlooked. It's very easy for a patient's motivation to slip. So the more contact we can have with them and the more opportunities we have to encourage them, the more likely their quit attempt will be successful. Now, the 5 A's are an effective evidence-based model for guiding a patient through the quit process. Most practices routinely ask patients about tobacco use and advise them to quit, but fewer practices actually assess the readiness to quit and assist the patient with medications or a referral to the helpline. In fact, only about 29% of tobacco users receive any assistance. So only about 29 to 30% of people who are trying to quit use evidence-based methods, and that's why our outcomes are so poor. There is evidence that full implementation of the 5 A's results in increased quit attempts and increased referrals to the helpline. And every intervention you do with a patient increases the likelihood of successfully quitting by 2.4%. Think about that. I like to use the analogy of a fundraiser when I talk about this. We've all seen the fundraiser thermometers at the side of the road, and each time you drive by, you see the level going up and up towards the ultimate goal. That's what tobacco interventions are like. So each time you have even a brief conversation about tobacco with a patient, it contributes toward that ultimate goal of complete abstinence. Even a conversation lasting less than 3 minutes is effective. So best practice, standardizing your system, okay, your workflow. Include all the 5 A's. Figure out who's going to ask, who's going to advise, who's going to assess, who's going to assist. Every visit we ask. And actually going back to that 5 A's, the last 2 actually provide the most help, the assist and the arrange. Every visit, we talk about tobacco use. We add it to the problem list. Get staff trained in basic tobacco treatment. Know the first-line medications, know how to use them, how to prescribe them. Keep patient literature in your office, keep it on site. Create e-referrals to the main tobacco helpline. So if you have an EMR in your practice, it can be set up to do an electronic referral to the helpline. We can also do fax referrals. Plan for follow-up, and these are reimbursable. I'm going to show you a few codes later. A visit 3 to 10 minutes is a reimbursable visit. So let's talk about the medication component of evidence-based treatment for a few minutes. So let's talk about nicotine withdrawal. So withdrawal symptoms impair the ability to stop using tobacco. Nicotine withdrawal can produce clinically significant mood changes and functional impairment. Nicotine withdrawal usually begins within 24 hours of stopping or cutting down on tobacco use. It peaks at 2 to 3 days after abstinence and lasts about 2 to 3 weeks. Prolonged symptoms beyond a month are pretty uncommon. So the most common signs and symptoms are anxiety, irritability, difficulty concentrating, and the least common are depression and insomnia. Cravings for sweet or sugary foods and impaired performance on tasks requiring vigilance are associated with nicotine withdrawal. Also, abstinence from tobacco can increase constipation, coughing, dizziness, dreaming, nightmares, nausea, and sore throat. Smokers with depressive disorders or like bipolar disorders or anxiety disorders or attention deficit hyperactivity disorders and even other substance use disorders may have more severe withdrawal. And severity of withdrawal can also be influenced by genetics. 50% of people trying to quit relapse within the first week, primarily due to withdrawal. People start smoking again to feel better. The best way to deal with withdrawal is to use tobacco treatment medications, either nicotine replacement medications or non-nicotine medications. So these are the FDA-approved first-line medications and their comparative efficacy. This is right out of the PHS guideline that I've referenced. The nicotine lozenge is not on this list. It was too new to be included when they did these studies, but recent studies have shown that the lozenge might be slightly more effective than the gum. So the estimated abstinence rate is the highest for varenicline in this table. Varenicline is a non-nicotine medication with the brand name of Chantix. And you can see that in someone using varenicline, they're 3 times more likely to quit than someone using placebo. And if you scan down the list, the nasal spray has the next highest abstinence rate, followed by the inhaler and bupropion, which is Wellbutrin or Zyban, and the patch. For the most part, we've always considered all the medications to be effective, and when choosing one for a patient, it comes down often to patient preference and cost. So here are all the nicotine replacement therapies, otherwise known as NRT. You can see that 3 are currently over the counter and 2 that are prescription. The transdermal patches are the most popular. They're long lasting, up to 24 hours, and you can get a relatively high dose of nicotine. It also has an excellent safety rating, and they come in 3 strengths, 21 milligrams, 14 milligrams, and 7 milligrams. And in dosing NRT, it's a 1-to-1 replacement. 1 cigarette yields about 1 milligram of nicotine, for example. So a person smokes a pack a day or 20 cigarettes, the best patch for them would be the 21 milligram patch. The tapering of the patch is all based on how well the patient is doing at the time and if they feel ready to step down to the next dose. Nicotine gum is a short-acting NRT available in 2 milligram and 4 milligram strengths, but it's important to know that you only yield about half that amount. So if you're chewing a 2 milligram piece of nicotine gum, you're only going to be yielding about 1 milligram of nicotine. You pop the gum in, chew it enough times to release the nicotine from the gum, and you can tell because the nicotine has a peppery taste to it. Then park it between the gum and the cheek. The nicotine is absorbed through the buccal mucosa, and 1 piece will last for about 30 minutes. The lozenge is very similar to the gum, short-acting, 2 doses, 2 milligrams, 4 milligrams. You hold it in your mouth like the gum. You suck on the lozenge to release the nicotine, then park it in your cheek. The inhaler is also short-acting. The nicotine is absorbed in the mouth, and to some degree, it's absorbed in the throat, but not the lungs. So it's not a true inhaler. Patients need instructions to sip like a straw, not to inhale. 1 cartridge lasts about 20 minutes, and the patient can use 1 cartridge every 1 to 2 hours. The inhaler delivers about 4 milligrams of nicotine from a 10 milligram cartridge. Then the nasal spray is most like smoking in that the patient gets a quicker burst of nicotine to the brain as it's absorbed in the nasal mucosa more rapidly than other NRTs. It can be especially helpful for people who are highly dependent. The dose is once or twice in each nostril per hour initially, and not to exceed 5 doses per hour or 40 doses per day. And the spray should go against the lining of the nose. It's not meant to be sniffed like into your sinuses, but right against the lining of the nose. So there are 2 non-nicotine medications that are both prescription. And on the left, we have bupropion, SR, sustained release. That's the generic name for Zyban and Wellbutrin. Zyban is the sustained release formula that has been licensed for tobacco dependence treatment. So bupropion acts in the brain by enhancing the release of neurotransmitters, primarily dopamine. It takes 5 to 7 days to reach steady state blood levels. So start at 1 week before the quit date. And it has a step start to it, 1 pill for 3 days, then twice a day after that. It's recommended to use bupropion for at least 12 weeks. On the right, we have varenicline, known by its brand name Chantix. Varenicline aids in tobacco treatment in 2 ways. As a partial agonist, it binds to and produces partial stimulation of the nicotine receptor, thereby reducing the symptoms of nicotine withdrawal. Secondly, because it binds to the nicotine receptor with such high affinity, it blocks nicotine in tobacco smoke from binding to the receptor, thereby reducing the rewarding effects of smoking. Varenicline can dramatically lessen the desire for nicotine and decrease urges to smoke. So varenicline also needs about a week to reach steady state blood levels. So a quarter of the dose is taken for 3 days, then half the dose for 4 days, then at the beginning of the second week, the full dose is started. Now, the Food and Drug Administration has removed the black box warning on bupropion and varenicline as of 12/16/2016. The risk for serious side effects on mood, behavior, and thinking when taking bupropion or varenicline is lower than previously suspected. The risk is still present, however, especially for those with current or past histories of mental illness such as depression, anxiety disorders, or schizophrenia. Providers should monitor for neuropsychiatric symptoms and counsel patients to stop taking bupropion or varenicline and call their healthcare professional right away if they notice any side effects on mood, behavior, or thinking. Just a quick note on varenicline, if people can't tolerate the full dose, then some people have done well on half the dose, and also the ramp-up times can be extended. So not just the 2-week ramp-up time, but that can be extended out to a matter of more weeks or even months. Combination medications, research is showing, excuse me, the effectiveness of these is very good. So combination medication may be especially helpful when there's been failed attempts to stop using tobacco, or there have been failed attempts with using just one medication. If a patient has breakthrough cravings or they have severe or prolonged withdrawal symptoms, combination medication can be helpful. And also if the person is a heavy tobacco user or has a very high level of dependence. So combining medications is still a new idea to many patients and even some health providers. So it's now considered safe to use NRT while still smoking or using smokeless tobacco or using any other nicotine product. There used to be warnings against using NRT while still smoking based on studies of patients who had heart attacks, but it turned out that those subjects had prior cardiac issues. The warning labels were modified by the FDA in 2013. We also now know that it can be very effective for people to use NRT for a pre-quit in order to help reduce cravings and learn some new behaviors and routines while beginning to reduce cigarette or smokeless tobacco use. There are higher quit rates reported at 6 weeks and 6 months when pre-quit NRT is used. Also, NRT carries no significant potential for abuse and has an excellent safety record and is well tolerated. So here's a little bit on the Maine Tobacco Helpline. It's free to all Maine residents. It's a flexible call, 1 call to 4 calls. Includes NRT if eligible. It's effective, it's free, it's friendly, it's confidential, 8 a.m. to 12 midnight. And if someone is referred to the helpline and we cannot reach them, we will send them materials. To enroll, an individual must have a Maine address so we can mail materials to them. But they could even be a part-time resident, like, for example, snowbirds. And most of the patients or participants on the Maine Tobacco Helpline are somewhat ready to make a quit attempt, and you have to be at least 18. Participants with Maine Care and State of Maine employees with Aetna are not eligible for NRT because NRT is a covered benefit under those plans. However, participants with those plans are still eligible for counseling, but they must obtain the NRT using their insurance. So again, the voucher program, nicotine patch gum or lozenge for up to 8 weeks, and patients are eligible every 6 months for that program. So what's the helpline's quit rate? We know that quitting cold turkey has a success rate of about 3 to 4%. And the quit line, overall quit rate for everybody is about 25.6%. And if the person has 4 counseling calls and used NRT, the quit rate is 40.4%. So I think that's pretty good. The quit rates vary slightly with gender and age and education level, type of insurance, and call utilization, so how many calls they had. And this overall quit rate derives from a 7-month follow-up survey with no tobacco use reported within the last 30 days. And this is 2015-2016 data. So how does one get connected? Well, there's multiple ways to get connected. The first traditional method is simply to offer advice, to call the helpline, handing a brochure, card, or sticky note with the helpline number. Patients may refer by using the quit link at quitlink.com. Just a note here, the quit link can also be used to refer someone else, such as a spouse or a family member, but keep in mind that that person has to agree to the referral. Another alternative form, which with the patient's approval, a clinician fills out and then to the EMR, making the referral process even easier. So a staff from the main tobacco helpline then calls the individual directly. So just a little bit on the screening visit. Decades of research tells us that clinicians can have an important impact on their patients' likelihood of achieving abstinence. A meta-analysis of 29 studies determined that patients who received tobacco treatment intervention from a non-physician clinician or a physician clinician were 1.7 and 2.2 times more likely to quit, respectively. So basically, any intervention, anytime you talk with a patient about their tobacco use, it increases the chances that they may quit. So while the intent of the LDCT visit is obviously to conduct the test, it's also another opportunity to offer tobacco treatment to patients. Like we discussed earlier, you never know when a patient's motivations can be at its peak. In many cases, the screening site is not going to be offering on-site tobacco treatment, which consists of counseling and medication. However, a patient, tobacco treatment intervention should be done with the patient. So asking the patient if they are interested in a referral to the main tobacco helpline is an example of such an intervention. Now, it's better to use an opt-out approach with patients. Here's an example. Part of our protocol, Mr. Jones, is a referral to the main tobacco helpline. Would you be interested in a referral? The patient can then choose yes or no. So research has shown that using this opt-out approach results in higher numbers of referrals to treatment. Lack of interest in quitting tobacco is not the end of the conversation, but it's the beginning. So when I hear someone say, I don't want to quit, I think what they're really saying is I'm not ready to quit, or I'm scared to try, or I feel bad enough already, I don't want to talk about it, or I've tried before and couldn't do it. So let the patient know that you'll be there for them when they're ready. Don't be judgmental, don't be shaming, be a partner with them. One good strategy is to ask them what they might consider. For example, perhaps they can give up 1 cigarette during the day and have a piece of nicotine gum instead, or a lozenge. People might be willing to consider small steps rather than the overwhelming thought of quitting completely. And believe in them. Use language that presupposes change. For example, when you quit instead of if you quit. Even if a person says, I don't want to quit, or I'm not ready to quit, keep asking them at every visit about their tobacco use. They expect it. And remember, every ask increases the likelihood of ultimate abstinence. So remember my fundraising analogy? So here's one of the 10 key guideline recommendations. And this is in quotes. It's essential that clinicians and healthcare delivery systems consistently identify and document tobacco use status and treat every tobacco user in a healthcare setting, end quote. So it's likely that the methods of communication of the screening results to the patient will vary. For example, in the Maine Medical Centers program, a negative result results in a phone call from the lung cancer screening site. This is an opportunity to talk with the patient and to note that the best way to prevent disease in the future would be to quit smoking. Treatment should also be offered, such as medication and counseling or a helpline referral. If the result is positive, a face-to-face visit is scheduled to discuss the results. At this visit, the provider can have a conversation with the patient and offer advice to quit, such as, Mrs. Smith, as we discussed treatment options for your lung cancer, quitting smoking would be one of the best things you can do to make the treatment outcome more successful. And then add, I can help. And again, treatment should be offered, such as medication and counseling or a helpline referral. So early detection of lung cancer with the LDCT screening and earlier medical interventions resulting in improved cancer treatments outcomes is no doubt going to reduce the toll of lung cancer in Maine. And this is indeed a worthwhile effort. Alongside that effort is the parallel effort to reduce the toll of tobacco in Maine. And indeed, the relationship is quite remarkable. If we were able to eliminate smoking, we would eliminate 87 to 90% of lung cancer in Maine. In solution-focused therapy, we talk about something called the preferred alternative future. The preferred alternative future is not today's reality, it's our vision for tomorrow. Also, the preferred alternative future is not just hopes and dreams. It can become real if we work towards it. So isn't it nice to think about a state that's tobacco-free and has a 90% reduction in lung cancer cases? So I'm going to try to make that real. Just a few considerations. So let's look at reimbursement. So these are the procedural or CPT codes for tobacco treatment sessions. The reimbursement varies, and it's based on the setting and the length of sessions, of course. And only physicians and mid-level providers are qualified or qualified healthcare professionals as defined by Medicare, and that's a big gray area, can bill directly for the services. RTs and nurses can get reimbursement as incident to under Medicare Part B. That's hospital, outpatient, and physician office, and Part A in the hospital. Of course, incident to means under the direct care of a physician or direct supervision of a physician. If you're going to provide tobacco use disorder treatment in your practice, here are the DSM-5 and ICD-10 diagnosis codes for tobacco use disorder and tobacco withdrawal. The codes you use depend on your settings. So medical settings will generally use the ICD codes, and behavioral health settings will generally use the DSM codes. And this is Maine Care coverage for tobacco treatment medications. As you can see, it is very good. So currently, Maine Care participant needs to get a prescription from their provider in order to get the patches, the gum, the varenicline, or the bupropion, and prior authorization for the other medications. But as you can see, it's very good. And this is actually very good news for Maine Care participants. So starting on January 1st, 2018, pharmacists are able to prescribe OTC NRT products like the nicotine patch, the gum, or the lozenge. And Maine Care participants will no longer have to get a prescription for these products from their doctor. So this eliminates potential barrier or obstacle to patients and gives them greater access to these products. So in closing, I'd like to mention tobacco treatment training events provided for healthcare professionals. These training events are brought to you by the Maine Health Center for Tobacco Independence on behalf of the Maine Center for Disease Control and Prevention. So basic skills is a one-day training, practical counseling strategies, an overview of the 5 A's brief intervention models, intensive skills drills down, assessment, development of treatment plans, counseling skills. Annual conference, we get national speakers for our annual conference. We look at new evidence research, innovative treatment strategies. So we encourage you to designate some key staff and send them to basic skills training. And this is also the path actually to become a certified tobacco treatment specialist in the state of Maine. And here are some just links and some resources that we've provided for you. And we've come to the conclusion of my remarks, and I'm going to turn this back over to Jessica. And here she comes. Here you go.
Thank you. Thank you so much. Hi, everyone. Thank you so much, Ed. That was terrific and a wealth of information. And I'm going to link with Lizzie here and basically check the chat box and see if we have any questions. It looks like we have one. Lizzie, can you help me with that component?
Hi, everyone. All right, it looks like our first question so far is, will we have access to copies of the slides? Which, yes, we will be posting those to our website, hopefully by tomorrow, but as soon as possible. And if anyone else has questions, please feel free to chat into that, either that Q&A or the chat box, whatever you see on your screen, and we'll try to answer those live. So.
Great, thank you, Lizzie. We'll give everyone a few minutes if there's anyone that has any questions. One of the things that I took away from this that I always seem to forget is the piece with the the gum. It's actually, we think of gum as just, chew, 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 but the key component of that, and I think that's something to really think about, how we educate patients in primary care and how we really drill down into this when we're giving them teaching information, is it's that, like you were saying, that mucosal, the way that it's absorbed. So I always find that that's a nice reminder to have I'm going to actually let him speak on that. Go ahead.
Okay.
Yeah.
Yeah, just on the tobacco treatment medications, you've probably often heard a patient saying, I tried that patch and it didn't work, or I tried the gum or it didn't work. There are three main reasons why tobacco treatment doesn't work, in quotation marks. One of those reasons is the patient isn't using it correctly. So we have to really be sure that we educate them on chewing the gum. For example, patients will chew the gum like they think it's regular gum. Too much nicotine will be released, they'll swallow it, they'll feel sick. And then they'll think, oh, this doesn't work. Or we talked about one-to-one replacement with the patch. Someone's smoking 20 cigarettes and they put a 14 milligram patch on, they're not using enough medication to cover the nicotine that they're intaking. So they will think this doesn't work when actually they're not using enough medications. So not using it correctly, not using enough medications to cover the withdrawal symptoms. And the third reason is they're not using it long enough. The recommendation for NRT is 8 to 12 weeks and longer if the patient needs that. And frequently someone will wear a patch and they'll wear it for a week. They'll feel good because they're not smoking, but they'll take the patch off, but they're still in that withdrawal phase and they tend to relapse to smoking. So if somebody asks you or somebody tells you the patch doesn't work or the gum doesn't work, the most important thing you can do is how are you using it? And then if they're not using it correctly, we educate them about the correct way to do it. All the directions for using these medications are in the package insert, but I don't know about you, but I've never read a package insert for any medication that I've taken. So it's basically, we have to educate them. The patch, for example, wear it above the waist, on the torso, on the arm, a hairless spot. Don't put the patch in the same place for 7 days. It's okay to wear it overnight if you don't have vivid dreams. If you get a rash, use some hydrocortisone cream. So those little things are very, very important. So educating people on the proper use of these medications is kind of key. It's kind of critical.
Thank you. And it looks like we have a couple other questions from Lance. Here it says, why doesn't Medicare cover Chantix or the Zyban starter pack? And sort of, I guess, follow up to that is, how would you suggest dealing with starting these medications if the starter pack isn't covered?
I don't have an answer for that. I don't know why Medicare doesn't cover it. I'm not familiar with that. And I think it depends on the individual patient. If they have access to, they have to have access to the medication, first of all, so I don't know if it's going to be likely that someone's going to use that medication if they don't have coverage for it. So I'm not exactly sure how to answer that question.
And another one, Andrea's asking, I need more information for patients. Do we have to get that in-house or directly from Maine Tobacco? I have another exam room I want to supply with these.
I think the best place to go would be the Maine Prevention Store. If you want to get lots of info, lots of handouts, rack cards, brochures, information on quitting, it's all available at the Maine Prevention Store. So you can go there and look through their inventory of things, and you'd be able to find a lot of stuff there that you can supply your exam rooms with and your waiting rooms.
And where is that?
That's online. Okay. So Maine Prevention Store, the link, we showed you the link a little bit earlier. And are people going to have access to these slides?
Yes.
Yeah, so you'll be able to go on and look at that link.
Great. We have a couple other questions. Anonymous here has said, the inverse relationship between economic/educational status and smoking rates is striking. Apparently, increasing the price of cigarettes is not effective. Can you comment?
I can. Back in the 1960s, the smoking rate in the country was about almost 50%. And now nationwide it's about 20%, 19 to 20%. And there's been all kinds of different initiatives that affect the smoking rate. So the Master Settlement Agreement back in 1997, 1998, where tobacco companies were sued and they had to start giving millions of dollars to the states every year in perpetuity. And that's why we're here. That's why the Center for Tobacco Independence is here, because of that money and that master settlement. Lots of money started flowing in, tobacco control programs, legislative initiatives, tobacco public service announcements and that type of thing. And that's affected the tobacco rate from almost 50% down to about 20%. What we have in that 20%, we have those are probably the people who are the most addicted to cigarettes and to tobacco. And it's a very, very difficult population. And that population is affected somewhat by things like increases in cigarette taxes. But really, one of the most important things for them is their smoking behavior. And we can see people not having food, not having medical care, and not having heating oil. Instead, they'll spend their money on tobacco products. So we have the most addicted population there. So in the legislative issues, for example, raising the tax, it does affect just a little bit people's behavior in smoking, but not to a great extent, particularly with this small core group that we have now. So, our efforts to reach those places by doing, initiatives like this one and CTI will go out to practices, for example, medical practices and behavioral health sites. And we'll do in-service trainings on tobacco treatment and tobacco medications. The helpline is available for people who are thinking about quitting and trying to quit. But I think just understanding that you call it the inverse relationship, we're dealing with a population of people who are the core, highly dependent people, and the last thing that they want to give up is their smoking. So, but just as I mentioned all the way through our webinar, repeated interventions, repeated conversations about it, every time that we can connect with them, every time we can talk to them about their tobacco use, helps them, move sort of along that path to readiness. But we can see the challenge, that we have. And in that 20% and 19 and 20%, we also have people with many other chronic illnesses or diseases. We have people with mental health disorders. We have people with other substance use disorders. So it's just a very challenging, even though it's 19%, it's still a very challenging and hard to reach group, for some of the reasons that we've talked about today.
Great. And it looks like we have about probably 3 or 4 more questions, and we're running out of time, but I just want to say that if we don't get to your question, we'll make note of them and try to get those answers out to everyone as part of our follow-up. So, all right, so one of the next questions we have is, actually this one's a comment. www.mainpreventionstore.com is where you can order all the materials for free that Ed has referenced. That's from Melanie Perry.
That's .org, actually.
Oh, it's .org.
Yeah.
She says to look under the collections tab at the top of the homepage. The first option on the drop-down menu is tobacco. Click on this and you'll see many materials that you can order for free. So that's great information to have.
Thanks to Melanie. Thank you, Melanie.
Let's see. One of our questions is, does the Maine Tobacco line provide a list of counselors?
You mean other than the counselors on the Maine Tobacco helpline? I mean, outside of here is the question. We don't provide a list of our counselors here at the Maine Tobacco helpline, but there is a tobacco treatment services directory that we maintain, and that's from people all over the state who are providing any type of tobacco service. We have that directory, and we can share that with you if you'd like to, so that then you can find in your particular area what resources might be available. Just keeping in mind that depending on where you are, you may have more or less access to services. But if that individual would like us to share the tobacco treatment provider services directory, then please let us know, contact us, send us an email.
Yeah.
And we'll make sure that we get that for you.
We can get that out, yeah. And that leads, I think, into our next question. How would very rural locations access your counseling help?
Well, one way is through the helpline. So anybody is eligible for the helpline. It's a telephone helpline. Also, the medication voucher program. We work with pharmacies in the individual's area, So they don't have to travel any distance in order to have access to that medication. So whatever pharmacy they use where they live, that's the pharmacy that we can send this medication voucher to. There are challenges with rural populations, very rural populations. And one of them is, for example, it is a telephone counseling service. And we've run into the situation where people have phones that they pay minutes for and run out of minutes, on their phone. So that can be very difficult. So it is a challenge for the rural populations. But one of the good ways to help them connect is through that telephone helpline. The new Voices of Nicotine Recovery.com is something we just recently discovered, and that's an online real-time self-help group. So we're trying to spread the word on that as well and get people familiar with that, so people can log on to the internet and they can actually go there, and they can it's just like going to an AA meeting. So if anybody's familiar with like the 12 steps, it's a 12-step program for nicotine recovery. So we recommend that as well. And then we try our best to, with our clinical outreach program, we will travel to all over the state to clinical offices, to primary care, to internal medicine, specialty practices, behavioral health. We'll provide in-service trainings free to those practices in tobacco treatment and evidence-based tobacco treatment. We also have virtual trainings that we can offer. And I didn't write this website in there, I should have, but the website is cti-trainingmaine.org/home, HOME. And that's our training website. And on that website, you can find videos, you can find webinars, recorded webinars. We do a series of live webinars. We're in the process of developing some asynchronous online training as well. So we're trying to broaden our reach to all parts of the state, and the virtual training is one way that we're trying to do that.
Great. And it looks like we do have a couple more questions, but we are a little bit after 1, so I'm going to say that the other questions we will certainly try to get to in our follow-up email tomorrow. You can always email us here at Quality Counts. It's mlcc@mainequalitycounts, all spelled out, .org. And we'll get to those questions, hopefully following up by email. And again, thank you so much to our presenter, and I'll hand it back over to Jess.
Hello, everyone. Just in closing again, on behalf of all of us, Lizzie, Ed, myself, the Maine Lung Cancer Coalition and Maine Quality Counts, again, thank you so much for joining us today, and hope that you found this very helpful in your work and your practice. We'd love to hear back from you on the survey. Please join us for the next Maine Lung Cancer Coalition webinar. We are looking to do this on radon and arsenic in the state, and just waiting for some speakers to confirm that we've reached out to. We know that there's a real need for this, and being able to really having a strong knowledge base for providers and clinical staff to talk to their patients about radon and arsenic and what that landscape looks like in Maine. So more to come on that. And then I would just encourage you to visit the Maine Lung Cancer Coalition website at mainelungcancercoalition.org as well. So again, thank you all for joining us. Again, like Lizzie said, if there's any questions we didn't get a chance to answer, please feel free to email them to us. And thank you all so much, and have a wonderful day.